Any questions, any comments regarding this muscle? Anything you guys have found interesting in your practice? And the reason, one of the reasons, one of the motivations why I like to go through these individual muscles, as much as we like to think of, that we have all the synergy and everything, the muscles kind of work together and there's a lot of synergy. At the end of the day, when it comes to injuries and rehabilitation, it's very important to look at individual muscles because of the fact that whether it's overuse injuries or trauma, these individual muscles are affected. Certain muscles are affected more than others. So therefore, when it comes to your rehabilitation, you have to look at, which muscle is the bigger problem. And unfortunately, in order to do that, you have to be able to identify the muscles. Let's see. There you go. Good. So let's start off. Everyone can see the screen. Perfect. Let's start off. So the tibialis anterior muscle it starts right up here at the tibial tuberosity area, and then it comes right down. As you can see, it comes right down and it impacts the all the way comes down, attaches into here. So the primary pain pattern, so the common pain pattern for tibialis anterior muscle is the anterior medial ankle area, dorsal and medial great toe. So these are some of the big signs that the tibialis anterior muscle might be an issue. Is you get someone that's coming in that has ankle pain. Now it can be ankle pain that they got a month ago, but also it can be ankle pain that they got 6 months ago and hasn't kind of gone away, and they keep getting ankle pain. Right away, that should give you an idea that this is the tibialis anterior muscle could be the issue. And the trigger points, they don't occur down here in the tendon, obviously. They never occur in the tendon. It's always in the muscle belly. So whenever you get someone that's coming in with ankle pain or even foot pain, let's say they got, their doctor has diagnosed them with gout, they got gout in their toe. Regardless, you always want to look and see what's going on in this tibialis anterior, because a lot of times I feel like even with gout, it's over prescribed, it's overdiagnosed. When the doctors, when the patients come and see the doctor right away, they got big toe pain right away. They think gout. That's the first step. So you as a clinician, you've got to be able to tease that out and figure out whether there's a muscle aspect to it. Pain referrals: anterior leg, dorsal ankle, dorsal region of the great toe, lower leg, ankle, foot, especially the great toe. So basically, there's a lot of referring from the tibialis anterior into the big toe. So you get a lot of soccer players or all of athletes that start getting something called the turf toe. Well, a lot of that turf toe can be coming from the shin, the tibialis anterior muscle. So basically, it's seen in adults and children, and these are just different studies that were conducted. So now the anatomical attachments, as you can see, so it's a lateral condyle of the tibia, upper half, 2/3 of the lateral tibia. So this is where the belly of the muscle is. And then also interosseous membrane and fascia. And so, for example, someone that has high ankle sprain, well, this muscle is also connected to the interosseous membrane, so therefore it will get impacted with any sort of high ankle sprain. And then the distal is the medial and plantar surface of the medial cuneiform, so it's coming right into here. So someone that's complaining of even plantar fasciitis type pain, I often look at the tibialis anterior as well, because as you can see, it's forming a little bit of that medial arch. And same as well, whoever is the chiro, I think we got Poonam on today. What's going to happen when this arch falls? This tendon's going to get strained, Because if there's no support here, what's going to happen is that arch is going to fall, and every time this tendon, this muscle is going to be tugged, which is going to create tendinitis within that muscle. So that's where some arch support is not only good for the tibialis posterior, but also the tibialis anterior as well. And then the base of the first metatarsal, there we go. Anything else here? So it talks about compartment syndrome. That's something we'll touch up on later on. So this is the anatomical attachments. This is a very, very important slide. Do you guys have any idea why it's an important slide? Can someone maybe, let's see if the speakers work. Can someone tell me why this is an important slide? Function and actions. Anyone? Anyone able to tell me why I've included this and why I'm gonna really talk about this part? Why this part is so important for when we're treating someone with tibialis anterior issues?
It tells more about the symptoms. Usually, the people will come with why, when do they have the pain? So they might come in with maybe when I'm keeping my first foot, or maybe when I'm taking off. Maybe that's why.
Exactly. This slide really, the reason why this is so important is because of your subjective. When you're asking the patient, when is the pain the worst? Is it a heel strike? What's going? These things are very important. Is it happening during running? Is it happening during takeoff? When is it happening? So during this subjective and history, you get an idea of which muscles might be firing at that moment. So that's why this slide is very important, because this EMG activity. So primary peak is at heel strike. For example, even myself, I'm having a little bit of issues with my tibialis anterior on my right side, and when I'm heel striking on my right, I can hear the foot slapping down at a lot higher volume than my left foot. Just because of the fact that tibialis anterior on that heel strike, on my right side is not able to control the front of my foot from striking as hard. So these are little things that you can use in order for, especially Poonam yourself as a chiropractor, because you're going to get a lot of foot people coming in for orthotics and different things. This will give you a good idea as to which muscles are firing and which ones aren't. And then secondary peak is at toe off. Why do you guys think the secondary peak would be at toe off? Anyone doesn't understand the slide so far? Isn't familiar with what EMG stands for? So the secondary peak is at toe off, meaning when your foot is in the air, that tibialis anterior has to work in order to keep the toes off the ground. So it's essentially going into dorsiflexion mode. And same thing with jogging and running. active during swing and early stance. So when someone says, I start getting shin pain or I start getting ankle pain as soon as my leg lands onto the pavement, well, you kind of have an idea of when it's happening. So these are, when it comes to the tibialis anterior, these are the key things you have to realize. It happens at heel strike and during toe off. Those are the points of when that tibialis anterior is firing the most. Jumping stops at the highest point and reactivates before landing. So these are all the things when the tibialis anterior gets activated. Active at the start and the end of the stance phase and helps foot clearance when stepping up. So this muscle is predominantly about 70 to 80% is slow twitch fibers, and then 20 to 30% is concentrated in the deep in the muscle. And I feel like when it comes to dry needling, especially, I don't know what you guys think, but when I'm dry needling, I like to go after these deeper muscles because I feel like they're the ones that kind of get spasmed faster. Kushbu, do you have any feedback on that?
I have recently dry needled the tibialis and with a post knee replacement, and she was having trouble with the ankle, and I did a needle deep into. I tapped the bone basically.
Yeah.
Yeah, and that really helped. Today she was not in any pain.
Yes, exactly. So people with knee pain, tibialis anterior can have an impact on that. And guess when they would have the knee pain? Usually at heel strike. When they're running or when they're walking and they're hitting the ground. Which I mean could be other muscles as well, but you have to look at the tibialis anterior. And the massage therapist that you guys are on this call, in order to get to this muscle, you do have to dig a little bit deeper. So don't be scared of pressing into that area. So these are the muscles that it kind of works together with. They do the dorsiflexion, and then these are the antagonists. So let's move on. So these are basically differential diagnoses. So these are other muscles that could be involved in this as well. When it comes to extensor hallucis longus, pain is over the first metatarsal, not the great toe. So that's the big difference. So often these guys mesh together. I mean, whether it's extensor hallucis longus, whether it's tibialis anterior, for me it is hard to figure out, like palpation wise, it's hard to figure out. You can generally get an idea of where it is, but it's not easy to palpate as well. But it gives you a good idea. If the pain is over the first metatarsal more, then you can be like, okay, it's extensor hallucis longus. And it's nice to kind of explain this to patients as well. Extensor digitorum longus, pain along the mid dorsal foot. More peroneus tertius mimics tibialis anterior, but there's no toe pain. So peroneus tertius is the pain is still along here, but it's not in the great toe. Flexor hallucis longus, pain is under the great toe, so not on top of the toe. So anyone that comes in with gout-like symptoms or any hallux pain, you got to look at these two muscles, flexor hallucis longus and tibialis anterior. So these are the muscles that it also, other muscles that can be involved in addition to the tibialis anterior. And then when it comes to nerve aspect of things, I don't know about you guys, but I get so many patients that have, obviously on imaging, have some nerve issues, L4, L5 usually, and then their main presentation is pain in the shin. How many of you guys encounter this? Is this quite common when you guys get the history? Oh, I get shin pain, and then pain kind of comes from the back and then goes right into the shin. Well, that's your L5 radiculopathy. So in addition to tibialis anterior pain, they can also have some L4, L5 issues going on. And we've all talked about anterior compartment syndrome. We've been taught that numerously. I think that's one of the big 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 topics there. Has anyone actually seen an anterior compartment syndrome? What it looks like? Because I feel like even this, it gets diagnosed quite a bit, but it's not really it gets diagnosed quite a bit. But I've had a patient come in and they said, they were diagnosed for anterior compartment syndrome. Like, what do they do? They're like, they didn't do anything for me. Like, 'cause a lot of times, even the doctors, they say, oh, you got anterior compartment syndrome, but it's something, it could very well just be bad shin splints. But I've never actually seen a true anterior compartment syndrome. Has anyone seen anything like that? Yeah, and I think it would be pretty obvious.
I mean, excuse me, hello?
Yeah.
Yeah, for the anterior compartment syndrome, I've never seen it like yourself. Like it would most likely just be like a misdiagnosis. However, like as someone who's just recently wrote boards, like it's a very, very like common symptom to appear even for chiropractic boards, like common diagnosis. So I feel like a lot of people just kind of diagnose it that way, like just because that's how we're taught. Like that's what the board kind of like wants you to pick anterior compartment syndrome. It comes up a lot, so I'm
I
assuming
know.
that's why a lot of practitioners like accidentally diagnose it as that.
Oh, exactly. But the biggest problem with that diagnosis is that this thing is so serious. I mean, this is like an emergency thing because with the anterior compartment syndrome, that can kill the nerves that are in that compartment. So that's why it's like, it's one of those things. Yes, we can diagnose it, but that's like an emergency thing where people have to go to the ER and get get like get decompression because
Mm-hmm.
that can cause nerve damage, and then you get true foot drop, and that the nerve's not, that nerve's damaged forever. So I feel like a lot of it is just like bad shin splints over the compartment syndrome, but I've never actually seen any compartment syndrome personally myself.
I had a patient in school that had it, and he had to get like his lower leg muscles removed. So all of his muscle mass is like gone from his lower leg.
Yeah, it's like serious stuff. It's not something, but once again, it's like what are the things to look for? I feel like one of the big things would just be like swelling and like very hot, like that area is very hot and swollen. That's kind of what I would see it as potentially. But just
And very shiny.
yeah, shiny. There you go. Yeah, shiny, hot, and just like massive inflammation in that area. Because shin splints, I mean, they are when you press in those areas, they are very painful, but it's not like it's hot, red, and shiny and swollen. So I think that's the big distinction. Because this perosteal irritation is very, very painful. And the reason why tibialis anterior is so heavily involved in this, so there's something called anterior shin splints and posterior shin splints. Anterior shin splints occur along this part, whereas posterior shin splints along this part. Anterior shin splints are most likely caused by tibialis anterior, can be extensor digitorum, can be extensor hallucis, all these guys at the front, whereas the posterior shin splints is mostly by the foot flexors and the tibialis posterior. Okay, so we got that. So what are some of the major causes of the trigger points? So this is another thing. So these two slides here, this one and this one is very important for your history. So when someone comes in with this type of pain, you have to try and identify, the activity that they've done and what could have caused the trigger points to come on. So it's something, it can be major trauma. I've had a patient that came in with major trauma, multiple surgeries. They have trigger points in the tibialis anterior. Severe impact, all of these things. Overloading, right? Eccentric contractions. What are people doing a lot when they're driving? I get so many people coming in with these new cars where it's just, they're always on the pedal, gas, 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 gas. I get so many Tesla drivers coming in with this type of issue where they have this tibialis anterior just gets overworked. Force for lengthening and then sudden impact can be that. Walking on uneven and slanted surfaces. This is where I think I got my problem. I don't know if any of you guys are encountering this, but with those cardon beds, they're nice, but you gotta use the frickin' tibialis anterior all the time, especially when you're on the sides. So I think this is where, from excessive use of using the bed and excessively, bringing it up and down, and using that footrest there or whatever the hell it is under the bed, I think that's what's giving me because I always use it with my right leg. Gas pedal. So these are all the things when people come in. What are they doing in order to? Gas pedal is a very common one, and usually if it's on the right side, a lot of the time it is because the gas pedal. Anterior compartment syndrome, increased muscle pressure, ischemia. Obviously, you're going to get that as well. Sudden stretch response as well. So sudden, and also it can be over time. How do you locate? Usually supine. You can find it on sharp edge of the tibia. Usually this is where I do my shock wave. So I use the shock wave along the edge of the tibia. And then for dry needling and then obviously hands-on stuff, I kind of go right into, so I shock wave a lot in here and then down in here. And then I also shock wave down here as well. Just kind of along the tendons a lot. And then obviously I do the dry needling. This is actually a good spot. And then I go in here as well. And same thing with massaging. This is the area you kind of want to focus on. And associated trigger points, so other muscles that can be involved. It can be peroneus longus. This is actually an interesting thing because I've never thought about this. Peroneus longus can be very commonly involved with, because it works with the tibialis anterior for foot stabilization and balance. So that's the muscle you want to always look at, and that's the guy on the side. Obviously, extensor hallucis longus and extensor digitorum, those are, they kind of work alongside each other. And these are some stretches and exercises you could do. What kind of things do you guys give your patients for this type of a muscle? What's a common home exercise that they can do?
Toe rises, most typically.
Toe rises, yeah. Toe rises, really depends on what stage they're in. Also, what I like to do is I like to get them a lacrosse ball, and I like to get them to put the lacrosse ball in here and kind of kneel on the ball to do some self-releasing. If they have a massage gun, get in there with the massage gun. I find that quite helpful. And depending on what they are, let's say if they're runners or doing something else or walk for 12 hours, I also like to prescribe them compression socks because I find that helps as well. Just kind of reduces the inflammation and allows better circulation through this area. But those are the main things that I do. And then obviously strengthening is a lot of the eccentric stuff and like you say, toe rises and different things like that. Any other questions? Comments? Good. So overall, like I say, this muscle is anytime you have anyone coming in with any ankle pain, you have to always look at this. This muscle is critical for any sort of ankle pain, any foot pain, and then also someone that's complaining of any L4-5 pain, any pain kind of down the side that goes down to the IT band, down the IT band, down the side of the leg, and into the side of the leg where the peroneals are. You always want to look at this muscle. And it is very active in a lot of people because a lot of daily activities that people do involve stressing this muscle a lot. And from based on history, when patients are saying, I get a lot of it when as my foot comes down, or as I'm about to, take a step, go up the stairs, I feel it in the shin area, or I feel it down in the ankle as well. So those are typical times when it's gonna be hurting the most, and also when someone's using the gas pedal. I find that's probably the most common thing these days that patients come in with. But when it comes to symptoms, the symptoms can be quite severe. You can have numbness. A lot of times patients also describe numbness and kind of numbness in the toe, the big toe. So when people say, "Oh, I got numbness in the big toe," you always want to check this tibialis anterior. And once again, you can do massage, hands-on stuff. You can shockwave it. You can do the dry needling. So there's a lot of different things. But yeah, I think that covers it. If you guys have any other suggestions, anything else, just let me know. I'll try to think of another muscle that we can tackle next month. But I think overall, in addition to doing all the other other tests, I think individually looking at each muscle and adding this to your toolbox as to how to assess someone that's coming in, especially with pain. This is very important because a lot of conventional tests and things that we've been taught in school really don't help you pinpoint to where that pain is coming from. For example, like ankle, anterior drawer test, like there's a bunch of these tests that you can do but they're mostly designed for ligament testing. They're not actually designed to kind of tell you where the pain is. Good, perfect. Any other question, guys? Other than that, thank you very much for coming out, and maybe drop something in the family group when you guys do have anyone coming in with tibialis anterior. Just say, "Hey man, thanks a lot. I found that tibialis anterior trigger point and it helped my patient." It would be nice to get some feedback for sure. Other than that,